So I'm going to talk about labor and birth, labor and delivery, labor and childbirth. So in labor situations, if a woman is in labor, the priority things you want to start having in mind is oxygenation and perfusion. So you want to start thinking, what is labor? So labor is coordination of sequences and voluntary intermittent intrauterine contractions, and birth is the actual event of the child coming out. So there are 4 things you want to consider when a woman is in labor. I call it the 4 P's. They are the 4 major interactive factors that will come to play when a woman is in labor. So during normal childbirth, the 4 P's are interrelated. These are activities that interrelate with each other, and they all come into play, and each of them will play a role that will move to the other stage for a safe delivery, for a safe childbirth process. So these 4 P's are: 1 is power. So I actually want you to take your pen and take notice from this video. You can always repeat it to make sense for you. You can always repeat it so that you will understand it better. So there are various activities, various things that have to come in play, that have to play from one step and it stop and the other one take over, and they are the 4 P's. So the 4 P's are the powers that are involved in labor, the powers that are involved in labor. This is another lesson on labor and delivery. Remember, we are doing maternity nursing. So the 4 P's, we have the powers, the passageway, the passenger, and the psychic. The passenger and the psychic. Now the powers, what are the powers? These are the uterine contractions that a woman goes through when she is in labor. So that counts as part of the powers, the contractions that the lady goes through. So we have forces acting to expel the baby. So there are forces that the contractions are producing that is helping to push out the baby. We have the effacement. Effacement is shortening. Effacement is shortening of. So the powers, we also have effacement, like I said. Effacement is shortening and thinning of the cervix during the first stage of labor. Labor has stages. It has 3 stages. So during the first stage, there's effacement, the shortening and thinning of the cervix. This will help to be able to open up to expel the baby. We have dilation. This is enlargement of the cervix, dilation. So the cervix dilates. I had mentioned to you that for the dilation, if it's 2 centimeters, you use your 1 finger. So each finger is counted as 2 points. So pushing effort of the mother during the second stage is also another thing that will come to play when it comes to the forces. So these are forces that play a role in labor. So let's talk about the second P, which is the passageway. The second P is the passageway. So what is the passageway? The passageway is the mother's rigid bony pelvis and the soft tissues of the cervix, the pelvic floor muscles, and the vagina that allow opening through the vagina for the baby to come out. So the passageway is when the baby come out. The baby and the placenta is delivered. That's the passageway. Now the passenger is actually the baby and the placenta. So they pass through the passageway and they come out. So there are forces, and these forces are the contractions that come into play, and the mother doing adding some effort by pushing out the baby. So we have the psychic, a woman's emotional structure that can determine her entire responses to labor. And this one is how you respond physiologically. You know, there are changes. There's anxiety, there's fear, the attitude of the mother. Like some women, just need to learn how to do breathing exercise. They are anxious, they are so scared, they don't want to go through the pain, which I know nobody actually want to go through pain, but all these things come into play. So the 4 P's, we have the powers, we have the passageway, we have the passenger, and we have the psychic of the mother. So these are the things that will come into play when it comes to labor and delivery. So let's continue. So the mother in the psychic stage has an attitude. So our attitude is the relationship of the fetal body parts to the one another. So we have the normal intrauterine attitude, which is flexion, in which the fetal back is round. So this one actually talks about the position and the lie of the baby. So we also have the transverse or the horizontal position, where the baby is lying in the transverse or horizontal position. Now let's talk about the presentation, the fetal presentation. So portion of the fetus that enters the pelvic inlet is the presentation. So the part of the baby that enters the pelvic inlet, like outlet, one that will open up to let the baby come out, is the presentation. So if the baby decides to push the hand out, is the hand that come out first. Now we have different types of presentations. We have the cephalic, which is head first. Head first. Cephalic is the most common presentation for babies, and cephalic presentation has 4 variations. We have the vertex, we have the military, brow, and the face. So that's the most common presentation for childbirth. Then we have the bridge. That is the buttocks presenting first. The bridge one that the baby will decide to turn towards the buttocks, to have the buttocks come out first. Then we also have bridge presentation, which has 3 variations. We have the flank, the frank area, the baby allowing the frank area to come out first. Then we have the full or the complete, where the baby will just cross the whole side. And then we have the footling, where the baby will decide to push one leg out and the other leg is crossing this way. So we also have the shoulder presentation. The shoulder presentation, the fetus is in a transverse lie, or the arm, back, abdomen, or side could present. So this shoulder lie, the patient can present it with the side, the back, the abdomen. If the fetus does not spontaneously rotate, or if it is impossible to turn the fetus manually, a cesarean section will be performed. So sometimes they have to do C-section to get the baby out. Presenting part, the fetal, the specific fetal structure lying nearest to the cervix. That's the presenting part, the part of the baby's body that is lying next to the cervix, ready to come out. Now the position, which is the relationship of assigned area of the presenting part, or the landmark to the maternal pelvis. The landmark to the maternal pelvis. Let's talk about station. This is the measurement of progress of descent in centimeters above or below the midline of the presenting part. So the mechanisms of labor. Let's talk about mechanisms of labor. We have various mechanisms that come into play when it comes to labor. And these mechanisms of labor are engagement. Number 1 is engagement. So we have engagement, descent, flexion, internal rotation, and extension. So let's talk about engagement. Engagement is the mechanism whereby the fetus nestle into the pelvis. The fetus finds its way into the pelvic region, ready to come out. Engagement also occurs when the presenting part reaches the level of the ischial spine. Now, descent. So descent is the process that the fetus head undergoes as it begins its journey through the pelvis. So the descent is continuous process from prior to engagement until birth, and is assessed by measurement called station. Let's talk about flexion. So what is flexion? Flexion is a process of nodding of the fetal head forward towards the fetal chest when the baby is nodding the head. So internal rotation of the fetus occurs most commonly from the occipital transverse position, which is assumed at engagement into the pelvis, to the occipital anterior position while continuous descending. Extension is the one that enables the head to emerge when the fetus is in a cephalic presentation or cephalic position. Extension begins after the head crowns. That means after the head of the baby it comes down. Then you have that one. Now the next one that we are going to talk about is restitution. Restitution is realignment of the fetal head within the body after the head emerges. Realignment after the head of the baby emerges. And then we want to talk about external rotation. So external rotation is the shoulders that is externally rotating after the head emerges, and its reconstitution occurs so that the shoulders in the anterior posterior diameter of the pelvis. So let's talk about expulsion, which is the actual birth when the entire body of the baby come out of the mother. So these are mechanisms that play a role in labor. So we have engagement, descent, fleshing, internal rotation, extension, restitution, external rotation, and expulsion. Expulsion, which is the last part of the labor mechanisms. Now let's talk about true labor versus false labor. So sometimes a woman will actually think she's in labor when a woman is pregnant, and especially towards the end. Sometimes it is difficult to understand which one is true labor and which one is false labor. So true labor is contractions that occur regularly. True labor contractions will be regular. It becomes stronger and it lasts longer and occurs closer together. It's consistent. Cervical dilation and effacement are progressive. It moves further. Then the fetus usually becomes engaged in the pelvis and begins to descend. So the engagement will happen when there is true labor. In forced labor, you don't see that. You will see that the woman will have contractions that will be irregular. So let's talk about forced labor. So in forced labor, like I said, the mechanisms or the forced labor process, you will see there's no cervical dilation. It doesn't actually progress. Effacement and descent does not occur. It's just false. So contractions are irregular without progression. So you can have contractions now, and then it just stops like in 1 minute, and for the whole day you will not have contractions. This is kind of false labor. Some women will rush and go for help. We have activities such as walking often relieves false labor. So when you try to distract yourself, it will relieve it. It wouldn't come again. But if it is true labor, it is going to progress. It's not going to stop. So mind you, false labor contractions are irregular and it does not progress. True labor contractions are regular and it progresses and it gets stronger and increases in intensity until the baby comes. And cervical dilation also goes progressively. So if you are able to do examination and then you put your finger there, you put your finger inside the mother's cervix and one finger goes through, that's 2 centimeters dilation. If you're able to put 2 fingers, that's 4 centimeters dilation. You're able to put 3 fingers, that's 6 centimeters dilation. And the dilation ends at 10. When it's 10, it's time to come out. It's time for the baby to come out. You actually see the baby's head. The presenting part would have been there. If a woman has been sleeping and wakes up with contractions, gets up and moves around, and her contractions become stronger and closer together, this is true labor, okay? If a woman has been sleeping and you wake up with contractions, gets up and moves around, and the contractions become stronger and closer together is a true labor. If the contractions go away, then it's false labor. So take note. We have breathing techniques during labor. So during the first stage of labor, you need to teach the mother how to do breathing techniques. So the first stage breathing, what do you need to tell the mother? How does that work? Like first stage of labor. So for each contraction begins and ends with a deep inspiration and expiration. So for each contraction for the first stage, it starts with a deep inspiration. So you tell them to take deep breath, and then they take deep breath when the contraction starts. Then exhale, then they exhale. Then slow paced breathing. This, you need to tell them to slow pace their breathing to promote relaxation. They should not pile them up. They should not pant. So slow paced breathing is used for as long as possible during labor. Let them do it slowly. Modified paced breathing. So modified paced breathing is used when slow paced breathing is no longer effective. Breathing is shallow and is faster. Then we have the pattern paced breathing, and pattern paced breathing sometimes is also referred to as the paint or pant blow. The pant blow. You see them panting. You see them panting. So after a certain number of breaths, modified pace breathing, the woman exhale with a slight blow, and then begins modified pace breathing again. So breathing to prevent pushing. You see, some women sometimes they just think like, I'm already in labor, I have to push. So we have breathing that you can do to prevent pushing, because the edge is there, but it's not actually time to push yet. So sometimes they just do it wrongly, and you don't want to get exhausted before time. So the woman blows repeatedly and using short puffs when the edge to push is stronger. This is for them to avoid pushing or to prevent them from pushing. So you tell them to do deep breathing so that it helps with when the contractions get stronger and the edge to push is much stronger. Second stage of labor. During the second stage of labor, there are several variations of breathing that can be used in the pushing stage of labor, and the pushing stage. So the second stage is actually the pushing. The first stage is the effacement and the presentation and cervical dilation. Second stage is the pushing stage, and the woman may groan, or they have they mourn in pain as she pushes. So they have prolonged breathing. You tell them to prolong their breathing and hold it while they are pushing with a closed glottis, and may result in a decrease in cardiac output. So because you are telling them to hold their breath for a while, they have their epiglottis closed, it can cause decreased cardiac output. So if holding breath while pushing is used, the open glottis method is limiting breath holdings to less than 6 to 8 seconds, which should be done. So you have to educate them to do the breathing less than 6 to 8 seconds. We have variability in fetal heart rate. We have variability in fetal heart rate, but I'm going to come back to this in a little while. So just give me a minute. I will come back to the variability. I really want to go into a little bit more into the stages of labor. I want to go a little more into the stages of labor. So, okay, so during the stages of labor, during the first stage of labor and the second stage of labor, where the presenting part has effaced and is in the pushing stage, we want to continue to monitor the baby. Now let's talk about fetal monitoring. Fetal monitoring. So the fetal monitor will display the baby's heart rate. Even though you are in labor, you still expect the baby's heart rate to be within normal limit, which is 110 to 150. 110 to 150. No, 110 to 160 is the normal fetal heart rate. So baseline is measured in between contractions. So when the contractions are there, you may not be able to get a good reading for the heart rate. It might be higher. So, or it is just wiggling all around. So the normal fetal heart rate during labor should be 110 to 160. So we have the device that will monitor intrauterine activities, whatever is going on in the uterus. So we have the fetal monitor that will also monitor contractions as well. Apart from monitoring the baby's heart rate, it also monitor contractions. So the baseline will be measured in between contractions. So when the contractions stop and the mother is relaxed, then they count the fetal heart rate at that time. So let's talk about, we have the external fetal monitoring. External fetal monitoring. So the external fetal monitoring is a non-invasive one that is performed with a toco transducer or a Doppler ultrasound, a Doppler ultrasonic transducer. So they use a Doppler to check this particular one. We have the Leopold's maneuver, which maneuvers which are performed to determine on which side of the fetal back is located, and the ultrasound transducer is placed on the area. This is how the Doppler is used. So they locate where the baby's back is, and then they put the Doppler on the back of the baby to read the heart rate. So the client is allowed to assume a comfortable position and avoid vena cava compression. So so maternal supine hypotension syndrome as well. So the preferred position is to have the client lie on her side to increase perfusion. So remember, for every maternal patient, your problem is oxygenation. So you want to have them lie on their side to increase oxygen perfusion to the heart. Now we have the internal fetal monitoring. This one is an invasive and requires rupturing of the membranes, and then they attach an electrode to the presenting part of the baby. So if the baby is coming out with the forehead, they attach an electrode. They go, after the cervix is dilated, they go in, they rupture the membranes and then the membranes, and they attach it to the forehead, and they read they monitor the baby. So the client must be dilated 2 to 3 centimeters to perform this monitoring. Dilated 2 to 3 centimeters to be able to perform this fetal monitoring. So we have the periodic pattern in fetal heart rate. We have the fetal bradycardia and fetal tachycardia. In as much as grown-ups have tachycardia and bradycardia, pediatrics also have. So let's look at bradycardia. Bradycardia is when the baby's heart rate is less than 110. It's less than 110 beats per minute for 10 minutes or longer. So you monitor the baby for up to 10 minutes and the baby's heart rate is like 100. Then you have watched it for up to 10 minutes and it's still like that. That means that's fetal bradycardia. Fetal tachycardia is when the heart rate is above 160. The same way, you want to monitor it and make sure you have monitored up to 10 minutes and it's still the same. So fetal bradycardia or tachycardia occurs if anytime it occurs during the labor process. You have to change the mother's position. You have to tell them to lie on the side, and then you have to give the mother oxygen and you let the doctor know. This is what you do. The first thing is positioning. The first thing is positioning followed by oxygen, and then you let provider know. So don't just see questions under this and you go pick to call the provider. You have to do something. You have to turn them to the side first to increase perfusion. Then you put them on oxygen. Then you call the provider after you have done your part. Let's talk about variability. This is fluctuations in the heart rate and the baseline of the heart rate. So we have the absent or undetected variability, and this is considered non-reassuring. So if there's no variability, it's not assuring, it's non-reassuring. So we have the decreased variability that can result from fetal hypoxia. When the baby doesn't get enough oxygen during the labor process, we will have decreased variability. A temporary decrease in variability can occur. That one too will occur when the baby is asleep. So sometimes the baby too will sleep, and then they will have variability. They will have the temporary variability or temporarily decreased heart rate for a while. So this usually will last for like about 30 minutes. So you monitor the baby for up to 30 minutes and you see if they're sleeping. Acceleration is a brief temporal increase in heart rate. So remember I said variability. Variability is non-reassuring. Variability is absent or undetected variability, which is considered non-reassuring, is fluctuations in the baby's heart rate. Acceleration is a temporal increase in the fetal heart rate for at least 15 beats per minute and more than the baseline, and it lasts at least up to 15 seconds. So usually it occurs, is a reassuring sign. Accelerations is a reassuring sign reflecting a responsive non-acidotic fetus. It means the baby is not in any distress at this time. So early decelerations are decreased in fetal heart rate below the baseline. The rate of the lowest point of the deceleration usually remains greater than 100 beats per minute. So early deceleration is usually a little greater than 100 beats per minute, but it's not up to 110. So early decelerations will occur during contractions as the fetus head pressed against the mother's pelvis or soft tissues. So if the baby's head pressed against mommy's pelvis or soft tissues, then you will have early decelerations. That's usually the main cause. So it returns to baseline by the end of the contractions. So at the end of the contractions, it does go back to normal. So early decelerations are not associated with fetal compromise and requires no intervention. So with early deceleration, you don't have to do anything. You don't have to do anything. There's no big cause for concern. Late decelerations, they are non-reassuring. Early decelerations were reassuring. Late deceleration is non-reassuring pattern that reflects impaired placental exchange or uteroplacental insufficiency. It means there's something going on with the placenta that it is not getting enough oxygen. So the pattern looks similar to early decelerations, but it begins well after the contractions. It usually begins after the patient has had the contractions. So the degree of decline in the baby's heart rate is not related to the amount of the uteroplacental insufficiency. So interventions for late deceleration will include immediately improving placental blood flow and oxygen to the baby. So you put the mother on oxygen. You turn them to the left side, that's perfusion, and then you put them on oxygen. So variable deceleration are caused by conditions that will restrict blood flow to the umbilical cord. Then variable decelerations do not have a uniform appearance of early and late deceleration. It's not in order just like that. So variable late decelerations are not reassuring. So if variable decelerations occur, you want to discontinue oxytocin if it was infusing, and then you want to change the woman's position change position, administer oxygen, monitor vital signs, and notify provider. So you assist with amnio infusion, that's intrauterine instillation of warm saline to decrease compression on the umbilical cord if it is prescribed. Now, hypertonic uterine activity. Hypertonic, we know hyper, that means it's too much. So this is assessment of uterine activities, and it can include frequency, duration, intensity of contractions, and uterine resting tone. So when you assess, your assessment is performed either by you palpate the mother's stomach with your hand or with an internal uterine pressure catheter. Then you put it in the uterus to check. So we have the nesting priority action for non-reassuring fetal heart rate. So if the fetal heart rate is not assuring, you want to identify the cause. Why is it not assuring? You want to discontinue oxytocin, that's the variability, the non-reassured, the late decelerations. You discontinue oxytocin infusion. You want to change mother's position, administer oxygen by face mask at 8 liters per minute, 8 to 10 liters per minute, and infuse intravenous fluid as prescribed. You want to prepare to initiate electronic fetal monitoring with internal devices if not contraindicated. So you also want to prepare for C-section if necessary. And you want to document all the events and the actions you have taken and how mommy responded to all the care that was given her. Now, stage 1 is the longest. Let's talk about the stages of labor. Stage 1. We have the stage 1, 4 stages of labor. I think I had mentioned 3 before, but it's 4 stages actually. The final part is the 4th stage. So labor has 4 stages. We have 4 stages of labor. So let's talk about the 4 stages of labor. 4 stages. So the of labor, you have to monitor the lady. That's actually the longest stage of labor ever. So under this one, when you're assessing the lady, you want to assess them for cervical dilation, and is 1 to 4 centimeters. We have uterine contractions. So the cervical will dilate in the first stages of labor 1 to 4 centimeters. Uterine contractions occurs every 15 to 30 minutes and are 15 to 30 seconds in duration. So when it occurs, when you start having the contractions, it's like it lasts for 15 to 30 seconds in duration, and then it become mild, and it's always mild in the first stage. So for 15 to 30 minutes, so you're gonna wait. After you have this one, it takes you like 15 to 30 minutes before you start feeling another contractions. So in this stage, in the first stage of labor, you know that dilation is just 1 to 4 centimeters. Then we have interventions. You want to encourage the mother and the partner to participate in the care. So you want to encourage the baby's mother. You want to assist them with comfort measures, positioning and ambulation. You want to have them be distracted a little bit. So you keep the mother and the partner informed of the progress. And or you can offer fluids and some ice chips. You encourage them to void every 1 to 2 hours. That is fine. Stage 1 is active phase. So there's cervical dilation, which is 4 to 7 centimeters. Stage 1. So stage 1. So we actually have the 4 stages of labor in stages. So we have stage 1, which is the latent phase. The latent phase. So the latent phase is the one that when you assess, you see 1 to 4 centimeters. Now we have the active stage, which is also under the first stage of labor. So the active stage. So remember the latent phase will start and dilation will only be 1 to 4 centimeters. But when you get to the active stage, which is still stage 1 of labor, which is the first stage of labor, then the cervical dilation is 4 to 7. Uterine contractions and activities are every 3 to 5 minutes. Remember, the latent stage was 15 to 30 minutes. This one is 3 to 5 minutes, and at 30 to 60 seconds in duration. So the other one, when it came, it will stay just like the other one will come in and stay, the contractions will stay like some 15 to 30 seconds. But now the contractions will stay for 30 seconds to 60 seconds. That's up to 1 minute. So remember, the intensity is supposed to increase. So what you do is encourage breathing exercise, provide quiet room, be supportive. You also tell them to take deep breaths, and then you try to get them distracted, get them some liquid, some chipsies, something to drink, something to eat. Voiding is 1 to 2 hours. Then we have the first stage of labor. Again, we have the transition phase. So I have the latent phase, and I have the active phase, and now the transition phase. At this stage, we have the cervical dilation, which is 8 to 10 centimeters. So if I am able to put 4 fingers in there and it goes in, that's 8 centimeters. If I am able to put my whole hand inside, that's 10 centimeters. At this point, you will start touching the baby's presenting part. So uterine activities are getting shorter. So from 15 to 30 minutes to 3 to 5 minutes, now it's 2 to 3 minutes apart. And it lasts for 45 to 90 seconds. That's 1.5 minutes. So when the contractions come, it doesn't stop. It pull you for up to 1.5 minutes before it gives you a short break, and it come back within 2 to 3 minutes. So interventions, you want to encourage enough rest. You want to wake mother at beginning of contractions so she can begin breathing, the breathing pattern. So you want to encourage them to also void every 1 to 2 hours if they want to. So the interventions for stage 1 will be to monitor the mother's vital signs, and then the baby too. You can use a fetal ultrasound like the Doppler that I spoke about. So the fetal heart rate, you want to assess the baby's heart rate during and after a contraction, noting that the normal fetal heart rate is 110 to 160 beats per minute. So monitor uterine contractions by palpating or using the Doppler machine to check, and the duration, and you check the intensity as well. This gives you information as to how far along the mother is with the labor. So you assess the station and the presenting part of the baby, and position by Leopold's maneuver. You want to assess with pelvic examination as well, and then you want to prepare for a Fenn test. So if the membranes have ruptured, you want to assess mommy because of the risk of prolapse umbilical cord. If the membranes have ruptured, you want to assess the mother and assess the color of the amniotic fluid, because when there is meconium stain in the fluid, it can indicate fetal distress. So when there's meconium in the fluid, in this the uterine fluid, what do I even call it? When there's meconium in the fluid, the amniotic fluid, then you want to suspect fetal distress. So now the first stage of labor have divided into the latent. We have the latent phase. We have the second one, which is the active phase. And then the third one, which is the transition phase. So latent, active, transition. The first stage is the longest of it all. So at the third stage, at the transition phase, the woman have dilated 8 to 10 centimeters, and that is where it can end. That means baby is supposed to be coming out. And that moves us to the second stage of labor. So the second stage, cervical dilation was already done. Progress of labor is measured by descent of the baby head through the birth canal and change in fetal position. So uterine contraction will occur still 2 to 3 minutes. Remember, the mother is almost there at the end. And when the fetal contractions come, it stays up to 1.5 minutes. So mind you that. So the mother will feel the urge to push at this stage. So at this stage, you feel like you have to push. So you want to help the mother perform assessment every 5 minutes. So during this stage, you want to help them with assessment of vital signs. You want to continue to monitor the baby with the fetal, the Doppler, and then you want to make sure the baby's heart rate is within normal. Be mindful of early deceleration, late deceleration, and variable deceleration, so that you can easily turn the mother to the side and then you watch them, you give them oxygen and notify provider. Now the third stage of labor, the third stage is the contractions that occur until the placenta is expelled out. So third stage, second stage, baby comes out. The third stage is the delivery of the placenta. So when the placenta comes, that is the third stage. So expulsion of placenta occurs 5 to 30 minutes after the birth of the infant. So the third stage of labor is the delivery of the placenta. So you want to monitor the mother's vital signs, provide parents with an explanation regarding expulsion of the placenta. So you answer their questions as they ask. Now, the fourth stage of labor is the period from 1 to 4 hours after delivery, 1 to 4 hours after the baby is out. You want to assess blood pressure. At this stage, you want to assess for blood pressure, pre-labor level, and then you expect the blood pressure to be at the level that it was when the woman was about to begin labor. Then you want to assess for the pulse, which is slightly lower than during it was in the labor. Or you want to also assess the fundus. So the fundus remain contracted in the midline, 1 or 2 finger breadth below the umbilicus. So when you use your finger to measure below the umbilicus, it's supposed to take you 1 to 2 finger breadth. So you monitor lochia. So the first 1 to 4 hours is the fourth stage. You want to monitor the lochia, which may be moderate in amount and red in color in this stage. So it will be moderate. It will be moderate in amount. It's not going to be too much, and then it should be red in color in stage 4. So your interventions will be for you to perform maternal assessment every 15 minutes. Remember, you have 1 to 4 hours to complete the fourth stage of labor. So you assess the fundus, the mother's abdomen every 1 hour, every 15 minutes for the first 1 hour, every 30 minutes for another 1 hour, and every 2 hours as long, or every 2 hours, or as per agency policy. Then you provide warm blanket, apply ice packs to the mother if needed. Then I'm going to talk about anesthesia, local anesthesia that is used. We know the epidural. It is given between the L3 and L4 lumbar region, the lumbar region. So we have the L3 and the L4. The position that we give is an anesthesia, is a medication to help control pain during labor. And then we also have the local anesthesia that is given during episiotomy. So if the woman had tears pushing out that baby, they will give the mother local anesthesia to help. Then we have the intrathecal opioid analgesics. It's a medication injected in the subarachnoid space and has a rapid onset action. It works right away. We have the subarachnoid spinal block. This is injected in the spinal cord as well, L3 and L5, to help with pain. General anesthesia may be used for surgical interventions. The mother is not awake in general anesthesia. So general anesthesia presents a maternal danger of respiratory depression, vomiting, and aspiration. So you need to take caution of aspiration precaution Obstetrical procedures, we have the Bishop score. The Bishop score is used to determine maternal readiness for labor and evaluate cervical status and fetal position. Oh God. The Bishop score is indicated before the induction of labor. Then we're going to have the 5 factors that are assigned a score of 0 to 3, and the total score is calculated. So a score of 8 or greater will indicate that the chance of a successful vaginal delivery is good, and the cervix is favorable for induction. They can induce labor. So induction is a deliberate initiation of contractions that stimulate labor, and elective induction may be accomplished by giving pitocin or oxytocin. So induction is a deliberate attempt just to initiate labor, initiate contractions. So they always like to induce labor. The medication of choice to cause the contractions is oxytocin. They give an oxytocin infusion to induce the labor. Then we have we have the process for giving that. You have to maintain, or you have to obtain a baseline vital signs before you start the oxytocin. And you have to get the baby's heart rate, the fetal heart rate has to be checked. Then you increase the dosage of oxytocin as prescribed only after assessing contractions. So fetal heart rate and maternal blood pressure and pulses are also going to be monitored strictly whilst giving the pitocin. So whilst you are giving that, make sure you are monitoring mommy and baby. So you do not increase the rate of the oxytocin when the desired contraction is obtained. So contractions that are frequent, the frequency is 2 to 3 minutes and is lasting for 60 seconds. It is okay. You don't want to increase the contraction. You don't want to cause hyper contractions in the mother. So an oxytocin infusion will be discontinued if the contractions are frequent and is less than 2 minutes, or duration is longer than 90 seconds, or if fetal distress is noted. They will stop the contractions. Now let's talk about amniotomy. Amniotomy. This one is artificial rupture of the membranes, which is performed by the obstetrician or the nurse midwife to stimulate labor. So when they rupture the membranes, they will stimulate labor and the baby will come out. Now, amniotomy is performed if the fetus is at 0 or a plus station, a 0 or a plus station. So amniotomy will increase the risk of prolapse, cord, and infection. It can increase the risk for uterine prolapse, umbilical cord, or infection. So you want to record time of amniotomy and the fetal heart rate and the characteristics of the fluid. You also want to notice the presence of meconium. Meconium stain amniotic fluid could suggest that there's fetal distress. So if it's bloody, it indicates that the placenta have ruptured, or there's trauma, there's fetal trauma. So if the amniotic fluid is bloody, it tells you something is not right. External version. We have the external version is the manipulation of the fetus from an unfavorable presentation into the favorable presentation of birth. So sometimes you see the midwife trying to manipulate the baby's position inside the stomach. So they're doing it through the mother's stomach. So the baby has pushed one hand, they push it back, and then they try to manipulate it. So when you see a presenting part of a baby that is coming out and it's wrong, you have to turn it back. And then they try to manipulate that. So that's the external version to help with the presenting part. Now let's talk about episiotomy. Episiotomy is when the mother gets tears. Episiotomy is an incision into the perineum to enlarge the vaginal outlet and facilitate birth. So sometimes the mother wants to push the baby out, but the space is not enough. the vaginal opening is not enough. The perineal is not wide enough. So they use the scissors to cut the mother at that point. They don't give it medication usually. They just cut the mother and then have the baby come out, and then they go back to suture it. Some women would get natural tears. They will not wait for that. They will now wait till they cut. The baby comes out with force, especially in precipitate labor. That's immediate, fast delivery. That's rapid delivery. The baby will just pop out and the mother will have a lot of tears. So after that, they will suture it. Then we have the forceps delivery. We have the forceps delivery. This is two double cross spoon-like articulated blades that are used to assist in the delivery of the fetal head. They use that to help deliver the baby's head. So you want to reassure the mother and explain the need for the use of forceps. So monitor the mother and the fetus during delivery. You want to check the baby and the mother after delivery for any possible injury from the forceps. So you want to assist to repair if there were any lacerations. Then vacuum extraction, a cup-like suction device is applied to the fetus head to facilitate extraction. As the name suggests, vacuum extraction is to help pull the baby out. So the suction is used to assist in delivery of the fetal head. You know, the baby's head is the biggest and the largest, hardest to come out during labor. So traction is applied during labor contractions until descent of the fetal head is achieved. So the suction device should not be kept in place any longer than 25 minutes. Should not be kept in place longer than 25 minutes. Then we have the cesarean section. So if cesarean section is when the fetus is usually delivered through transabdominal lower segment incision of the uterus. So they cut the mother's lower abdomen and they get into the uterus and they bring the baby out. So with this one, you want to prepare, mommy for pre-operative. So we have the pre, intra, and post. So you want to explain the procedure to the mother. Sometimes for some reason there is late deceleration. You want to explain the need for C-section. You want to explain the need for fetal distress and the reason why the mother has to have a C-section. So pre-procedure, you have to do education. You have to educate the mother. You have to prepare them, and then you have to also be ready to answer their questions. So we have intra procedure that the nurse will also play a role in that. We have the post-operation time that you have to monitor. So you monitor their vital signs, perform their fundal height and assessment, and you provide pain relief, encourage turning, coughing, and deep breathing, encourage ambulation. So just because they have surgery, you don't have to keep them in bed. You encourage ambulation as much as tolerated so that they can help themselves. So we have a tender uterus and foul-smelling lochia may indicate endometritis. So if there's an inflammation in the endometrium, then there can be foul-smelling lochia. The lochia coming out can be foul-smelling. A productive cough or chills may indicate pneumonia. So after a mother has finished delivering and then you have productive cough and you having chills and fever, it may be pneumonia. Painless redness or edema of an extremity may indicate thrombophlebitis. Thrombophlebitis. Pain, redness, or edema of an extremity may be phlebitis, thrombophlebitis. So you want to take notice of that. Now, the last part I just wanted to also hit on was the fetal heart rate pattern, non-reassuring fetal heart rate pattern. So if there's non-reassuring, you're going to see symptoms. So the symptoms for the non-reassuring fetal heart rate is bradycardia, tachycardia, late deceleration, prolonged deceleration, hypertonic uterine activity, and decreased absent variability, and then variable deceleration falling to less than 70 beats per minute for longer than 60 seconds. That is 1 minute. So, and during labor, they also have a labor chart that you monitor. So it's printing out the graph as in between contractions, it is checking the baby's fetal heart rate. So remember, I mentioned we have 4 stages of labor, and under the 4 stages of labor, the first stage is stage 1. So the stage 1, we have the latent phase, we have latent phase of labor. Then we have the, give me a minute. So we have the latent. So we have the latent, we have the active phase, and we have the transition phase. Latent, active, and transition phase for labor stage 1. And we have labor stage 2 as well, which is characterized by the baby delivery itself. So the first stage of labor is from the initial feeling of contractions, when the mother starts getting the sign that I am in labor. You start having the contractions, that you have true contractions, not false labor. We have the false labor and the true labor as well, I spoke about. So you have the true labor, and then the contractions will come regularly. And it starts with 15 to 30 minutes apart. Then it's reduced down to 3 to 5 minutes apart in the latent stage. And then it gets to the second stage, which is time for the baby. So the cervical dilation will dilate up to 10 centimeters. So the second stage of labor, it is already dilated up to 10 centimeters. Second stage is for you to deliver baby and deliver. Third stage is for you to deliver the baby. Second stage is baby delivery. Third stage is the first one. No, fourth stage is 1 to 4 hours. Fourth stage is 1 to 4 hours after delivery. So third stage is the delivery of the placenta, the baby. Then the second stage is the dilation stage. The first stage is just the beginning of the labor process. So you want to take notice of all these things. So cervical dilation is complete in the second stage, and the baby uterine contractions and the curve, it will occur every 2 to 3 minutes apart in the second phase. So at this phase, you want to perform assessment and you know what is going on with the baby. So the third stage is the expulsion stage, where the baby actually comes out, pop, and the placenta follow. Fourth stage is when you monitor the mother first 1 to 4 hours after baby. So on this note, I'm going to end this lecture here. If you have questions, if you don't understand anything, just write down your question and then get it up to me. When we meet in person, we will talk about it. So just let me know. Let me know. But I want you to take a book. I want you to be able to go over this note. You can listen to this video again, but please make sure you are practicing questions. Make sure you are practicing questions. So I'm going to show up, I'm going to come up with another video that will talk about problems with labor and childbirth. And our last topic, our last discussion on this topic will be postpartum period. Postpartum, the first 1 to 6 weeks, what happened. So those are the 2 left for us to talk, and the maternity nursing, and we close that chapter. So watch out for that one as well. And have a good night. Goodbye. Thank you.